This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Stacey Clardy from the Salt Lake City VA and the University of Utah. Today, we're beginning part one of a two-part series where we go through practical updates on monogenic disorders that mimic neuroinflammatory diseases. This is basically what all of us need to know in our clinics. These patients are sitting in the clinics as seronegative NMO or seronegative autoimmune encephalitis or an atypical multiple sclerosis. So this really does matter because it impacts treatment. Joining me are Ayush Gupta from the Department of Neurological Sciences at the University of Nebraska Medical Center and Kuntal from the Division of Neurogenetics and Neurodevelopmental Pediatrics at Children's National Hospital in Washington, D.C. They are co-authors on a recent Neurology Genetics review on this topic. The title of that article for you to reference, and I have printed it out, it's a great one to keep nearby, is Monogenic Mimics of Neuroinflammatory Phenotypes in Children and Young Adults, an Evolving Landscape. Ayush and Kuntal, thanks so much for being here.
Thank you, Stacey, for having us. We are very honored to be a part of this podcast.
Thank you, Stacey. Very excited to be here.
Let's jump right in. Ayush, why are monogenic mimics such an important diagnostic problem right now?
As science has evolved, we have learned so much about these rare neuroimmunological disorders, and unfortunately, that success has become part of the problem. Once a case looks enough or just enough like an acquired demyelinating syndrome, perceived to what is known as anchoring bias, which makes it very hard to step back and consider any alternative diagnosis. There are a lot of reasons why we are recognizing these disorders in a lot more in pediatric age group, but still missing a lot in adults. There are several genetic disorders. There are leukodystrophies, mitochondrial disorders, inborn errors of immunity, etc. And these genetic disorders have their own distinct phenotypes. As the sciences evolved, many of these genetic phenotypes that we know of are not always the case. We have different leukodystrophies that are being recognized more and more, for example, in older age group and adult population with a very variable phenotype. And similar is the case with a lot of other genetic disorders. These atypical presentations can easily trick us into thinking about an acquired disease first, and that anchoring bias that we have from before just lets this disease to remain undiagnosed. There are a couple of patterns I like to ask people to pause in certain circumstances. For example, if you're going to diagnose primary progressive multiple sclerosis and the patient has no spinal cord lesions, that is a big red flag. You have to ask whether this could be something like a genetic disorder in that case. Similarly, if somebody is having back-to-back attacks of what looks like an optic neuritis, episodes which mark sustained visual loss, that should push you to think beyond the classic inflammatory phenotypes, including monogenic or mitochondrial causes. Our recognition of inflammatory phenotypes is also outpaced our comfort with genetics, and that is a very important point nowadays. Genetic testing is easy to order. You can just order a panel and do it, but the careful interpretation is not. And most of us are not trained to live in that gray zone of what is positive, negative, and VUS, and segregation studies, or to know when to pick up a phone and call our genetics colleagues and neurogenetics colleagues. As testing has moved into, even I see in the adult neurology practice, there's a real need for practical guidance on when to start testing, when to stop, and how to interpret what comes back. So this adds an extra layer of complexity to even diagnosing those genetic disorders. And if this was not complex enough, there is even more. A lot of single gene disorders that are increasingly recognized to present like relapsing lesions with inflammatory phenotype. That is to say, they can have enhancement on MRIs, they can have pleocytosis on CSF, even steroid responsiveness. And if we miss these diagnoses, we lose a therapeutic window for the targeted therapies. So it is becoming more and more realistic and practical to recognize them early on and treat them early on. With all these circumstances, it's getting to the point that it's an important diagnostic problem, but it's also a practical and clinical problem.
So well said. You've really hit on many of the struggles that I've experienced when I'm in my autoimmune neurology clinic. Cost aside, which is a huge challenge on the adult side, it is, as you've pointed out, what are the appropriate red flags? And then again, you said the further challenges, sometimes you will get a mutation and maybe it's been well described in the rheumatologic literature, but it hasn't yet been reported to manifest in the central nervous system. And so now you're left wondering if it's relevant at all. Yeah, really what you said has resonated with me on so many levels. And so can you expand what happens to patients when we get this wrong? It is so much work and so much effort to sit there and think about genetics. It is not necessarily how we've all been trained. There's not a huge emphasis on this in our clinical learning when we become physicians. What are the real world consequences if we don't take the extra time to do this? And if we label a monogenic disorder as, say, a refractory autoimmune disease?
So it's really important to not miss a monogenic disorder, and especially if it's a treatable inborn error of metabolism. And as Ayush was referring to, if there's an anchoring bias and it's treated as a refractory autoimmune condition, one of the major problems is escalating immunosuppressive therapies. And you may continue those therapies, but it's not going to help. And secondly, the underlying neurogenetic disorder will continue to progress, and some of those may have a specific treatment. For example, mitochondrial vitamins and ketogenic diet, and will lose the opportunity to treat those disorders. Taking a step back from that anchoring bias and keeping genetic testing as a part of your protocol for those seronegative cases and the ones that are not responding to treatment, that should be a part of your diagnostic protocol.
In the patients we all have where we've listed our diagnostic criteria, you gave the example, Ayush, of a primary progressive MS. But this happens a lot of times. This is well published even in the literature, like people who partially meet a Sussex or partially meet a Behçet's, all these sort of old eponymous labels. And you're looking at the criteria and you're getting 2 out of 3, 3 out of 4, and you're squeezing it in there regardless because it's your best fit. These are the patients where you have me thinking, yeah, we really need to move genetics up above that if they're not truly fulfilling and meeting all of the criteria. So let's get into some specifics. I'm a concrete learner here, Ayush. So let's walk the neuroaxis a little bit. Give us examples. So if we start with a patient who has some supratentorial white matter disease, right? I'm looking at that MRI of the brain. They were sent to me as a referral for rule in, rule out multiple sclerosis, or maybe someone said, could this be ADEM? Give me an example of a classic genetic disorder that you see in these common referrals for rule out demyelinating disease.
Yes, one of the classic examples that is often labeled is X-linked adrenoleukodystrophy, specifically the cerebral type, which is actually a very treatable disorder if caught early. So this disorder can present with white matter lesions early on. And as we have learned more and more about this disorder, we can safely say that the earliest involvement is actually in the corpus callosum, which is in fact a common site for our multiple sclerosis lesions. The lesions in X-linked adrenoleukodystrophy are posterior predominant to start with, and they involve the splenium of the corpus callosum as initial presentation. And then we have some of these cases which involve the posterior white matter. And what is happening there is basically there's a genetic defect in a peroxisomal transporter that leads to cellular injury and inflammation. So it is actually a demyelinating type of disorder, but the cause of demyelination is genetic rather than autoimmune. The thing that really differentiates it from multiple sclerosis is the posterior predominant confluent involvement and a rim of peripheral enhancement, which our autoimmune colleagues will know can be seen in multiple sclerosis. But this kind of enhancement is very on the periphery and also very symmetric. I say this is an important differential because it is a very treatable disorder, so much so that now it is a part of newborn screening program for a lot of our patients, we are able to detect the disorder early and early. This cerebral form of X-linked adrenal leukodystrophy used to be 100% fatal disorder. And now, thankfully, we have a very described treatment of hematopoietic stem cell transplants as well as gene therapies, which can lead us to a significant improvement in clinical symptoms and prevent the fatality. So that is one example that we have put in our paper, but there are several other leukodystrophies that can predominantly affect the white matter, but present like white matter disorders that are acquired. I recently was going through a case report of tumefactive demyelination as an initial presentation of metachromatic leukodystrophy. In that case, there were initial tumefactive large lesions, but there were also presence of simultaneous other areas of white matter involvement, which was a very different pattern than multiple sclerosis with isolated tumefactive demyelination. One thing that I want to highlight about vanishing white matter disease is it's one of those disorders which has a very heterogeneous phenotype. For example, I had a patient in their 50s who presented with a progressive gradual cognitive decline and was labeled as white matter disorder on MRI. This notably happened after a trauma. This is one of the disorders where trauma, a minor infection, can lead to triggering of that inflammatory process in the brain and present as white matter dystrophy. This also highlights that this disorder and leukodystrophies in general, it's not just a pediatric problem. As we are learning more and more, this is a pan-neurological issue that other adult colleagues should know as well.
Did highlight what I was just thinking, which is these patients show up in the adult clinics too. So we're not off the hook on the adult side. We really do need to be thinking about it. What about encephalitis-like presentations? So seizures, altered mental status, patients that may come in as classified as NORSE or FIRES, or otherwise just having a sort of sudden or subacute cognitive involvement. What genetic categories does that sort of trigger in your mind that you've seen as misdiagnoses?
I agree that viral and autoimmune encephalitis, of course, are on our differentials when somebody presents with seizures and altered mental status. But sometimes genetic categories can also masquerade these seronegative, like you said, autoimmune encephalitis. Conditions like mitochondrial encephalopathy can present with deep gray involvement and movement disorders, along with fluctuating encephalopathy. This can very much mimic autoimmune or viral causes. Notably, however, non-inflammatory CSF is often the case. Usually the episodes tend to lead to significant partial cognitive or neurological deficits. And then these patients will have back-to-back attacks with metabolic stressors or stress response or dehydration. And that is one of the ways you can distinguish the time course and worsening deficits with stressors. Aicardi-Goutieres syndrome and other interferonopathies, which are interesting disorders which actually are on the interface of genetic and immune conditions, because there is a genetic basis for these disorders, but that leads to immune reaction and inflammation. They can present with a similar gray matter type of involvement with motor movement disorders and encephalopathy. Again, these disorders are more seen in younger age group, in children and adolescents and maybe younger adults. Another key, especially in the epilepsy phenotypes that sometimes we see, is epilepsia partialis continua that can be seen in patients who are adolescents or adults as well. And together, epilepsia partialis continua and progressive encephalopathy should raise suspicion for genetic disorders, especially some mitochondrial epilepsy syndromes like Pol-G-related diseases. These are the common ones that we can look at as differentials for encephalitis-like presentations.
And I am especially picking up on what you said there about Aicardi-Goutieres. I've seen some variants in patients that I've been evaluating for that. What would that change in terms of treatment if someone was confirmed to be on that spectrum of conditions?
Aicardi-Goutieres syndrome is a very interesting group of disorders, and it's not a single gene that causes it. So treatment depends on what is the phenotype, especially if this is an infant or a younger child who's presenting with persistent fevers, chilblains, and calcifications on the brain. That's when you suspect this as a classical Aicardi-Goutieres syndrome. And in those cases, there are specific treatments that can help. The treatment is aimed at specific pathogenesis of this disorder, which is interferon abnormality, interferon response. So disorders like this can be treated with a group of medications called JAK-STAT inhibitors. And baricitinib actually is one of those disorder targeting medication that has been shown to help not only with the chilblains, but also can help with neurological deficits. So that is one spectrum. The other spectrum of Aicardi-Goutieres syndrome, which is thought to be more in the adults, is progressive spasticity and dystonia. In those cases, the inflammatory response is thought to be not as severe, so there is not much data on what and how to treat them as of yet, but the science is evolving. So in future, we might be looking at more specific types of treatments for this disorder. In fact, Aicardi-Goutieres syndrome is thought to be one of the most common leukoencephalopathies or leukodystrophies affecting the adult population. So I just want to highlight this as well, that for Aicardi-Goutieres syndrome, many of the JAK inhibitors are under study, but they have not been FDA approved yet. So the treatment is still experimental.
Wow, I'm learning a lot. This is great. I'm going to keep going because you're just a wealth of knowledge. So let's move a little toward the brainstem area. And here, you heard me mention it just a second ago about eponyms. It seems to me that a lot of the trouble here with the diagnostic anchoring is tied in some ways to these eponyms or syndromic descriptions that historically have been useful. But I feel like now when they're in the chart, often we then stop looking further toward the pathophysiology. So what I'm thinking of in particular now in the brainstem is clippers. We've covered a little bit of this in the past on the podcast, talking about what some of the clippers patients end up having. But you tell me, what do you think? What's your experience when you've come across patients with this label of clippers?
Yes, I have come across through a lot of young adults and older adults with similar kind of presentation. And I think of clippers more of as a radiological diagnosis, to be honest, where a radiologist interprets like clippers-like findings or brainstem inflammation. And like you said, there are a lot of differentials, not just including genetics, but also something like a brainstem tumor can present with clippers-like presentation. In terms of genetic disorders, the one disorder that is a never miss for folks out there is CNS limited hemophagocytic lymphohistiocytosis, HLH for short. This is monogenic immune dysregulation type syndrome, where your immune system, specifically the innate immune cells, start attacking in the central nervous system. It specifically can affect brainstem and cerebellar areas and cause punctate or patchy enhancing lesions that can be very beautifully steroid responsive. But the problem is that you give steroids, they get better. You wean steroids, they get worse. So that is one spectrum of CNS HLH. The other spectrum is an HLH with systemic involvement, where these patients can be very sick with multi-system involvement. In terms of clippers, like I said, CNS HLH can be a very challenging monogenic diagnosis. And more specifically, it's important to recognize this because this is a very treatable disorder. There is near complete remission of this HLH with hematopoietic stem cell transplant. And there are multiple medications that can be used in between when the patients are sick to help with the disorder itself. Sometimes we talked about it in our autoimmune neurology meeting yesterday that routine lumbar puncture testing may not be sufficient enough to diagnose this. For example, in CNS HLH, if you are doing lumbar puncture, there are some additional markers that can be looked at. Neopterin levels in CSF can be a marker of inflammation. Flow cytometry analysis showing specific subtypes of cells and NK cell functional analysis can be useful. Unlike systemic HLH, CNS limited HLH is also challenging because a lot of the features of systemic HLH do not manifest. So it can be just restricted to CNS. That's a very important condition to not miss when you are thinking about clippers, even slippers, which is the supratentorial form.
Yeah, very challenging. I'll just go back too quickly and say you mentioned that autoimmune meeting yesterday. Just to specify, that is open to anyone. That's the AAN Autoimmune Synapse. And if you join that, there is a monthly teleconference where experts like Ayush from around the world share challenging cases and educate all of us on autoimmune neurology issues. Ayush, this is fantastic. I have more questions. I want to ask you about the spinal cord. I want to ask you about optic neuritis. I want to ask you about even bigger issues. So we will cover more with both of you in part 2 of this episode, discussing your paper in Neurology Genetics, Monogenic Mimics of Neuroinflammatory Phenotypes in Children and Young Adults, an Evolving Landscape. So please come back and join us for part 2 of this high-yield clinical pearl-filled review of genetics and how we should be looking at our patients with suspected neuroinflammatory diseases to be sure that we don't miss these critical diagnoses, many with emerging treatments. Thank you both, Ayush and Kuntal, for this week's episode.
Thank you for having us.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.